What is trauma? According to SAMHSA's Trauma and Justice Strategic Initiative, trauma results from an event series of events or a set of circumstances that is experienced by an individual as physical or emotionally harmful or threatening, and that has a lasting adverse effects on the individual's functioning and physical, social, emotional, or spiritual well-being. Trauma can affect people in every race, ethnicity, age, sexual orientation, gender, psychosocial background, and geographic region. A traumatic experience can be a single event, a series of events, and or a chronic condition like a childhood neglect or domestic violence. Trauma can affect individuals, families, groups, communities, specific cultures, and generations. It generally overwhelms an individual's or community's resources to cope, and it can often ignite the fight, flight, or freeze reaction at the time of the event or events. It frequently produces a sense of fear, vulnerability, and helplessness. Often, traumatic events are unexpected. Individuals may experience the traumatic event directly, witness an event, feel threatened, or hear about an event that affects someone they know. Events may be homemade, such as a mechanical error that causes a disaster, war, terrorism, sexual abuse, or violence, or they can be products of nature, such as flooding, hurricanes, tornadoes. Trauma can occur at any age or developmental stage, and often events that occur outside expected life stages are perceived as traumatic, such as a child dying before a parent, cancer as a teen, personal illness, job losses before retirement. It is not just an event itself that determines whether something is traumatic, but also the individual's experience of the event. Two people may be exposed to the same event or series of events, but experience and interpret these events in vastly different ways. Various biopsychosocial and cultural factors influence an individual's immediate response and long-term reactions to trauma. For most, regardless of the severity of the trauma, the immediate or enduring effects of trauma are met with resilience, the ability to rise above the circumstances or meet the challenges with fortitude. For some people, reactions to a traumatic event are temporary, whereas others have prolonged reactions that move from acute symptoms to more severe, prolonged, or enduring mental health consequences, such as post-traumatic stress and other anxiety disorders, substance use and mood disorders, and medical problems like arthritis, headaches, or chronic pain. Others do not meet established criteria for post-traumatic stress or other mental disorders, but encounter significant trauma-related symptoms or culturally expressed symptoms of the trauma, such as somatization, in which psychological stress is expressed through physical concerns. For that reason, even an individual does not meet the diagnostic criteria for trauma-related disorders. It is important to recognize that trauma may still affect his or her life in significant ways. For information on traumatic events, trauma characteristics, traumatic stress reactions, and factors that heighten or decrease the impact of trauma, see the next presentation on trauma awareness. and understanding the impact of trauma. The past decade has seen an increased focus on the ways in which trauma, psychological distress, quality of life, health, mental illness, and substance abuse are linked. With the attacks of September 11th in 2001 and other acts of terror, the wars in Iraq and Afghanistan, disastrous hurricanes in the Gulf Coast, and sexual abuse scandals, trauma has moved to the forefront of national consciousness. Trauma was once considered an abnormal experience. However, the first national comorbidity study established how prevalent traumas were in the lives of the general population of the United States. In this study, 61% of men and 51% of women reported experiencing at least one trauma in their lifetime, with witnessing a trauma, being involved in a natural disaster, or experiencing a life-threatening accident ranking as the most common events. In the wave of the second national epidemic survey on alcohol and related conditions, 71.6% of the sample reported witnessing trauma. 30.7% experienced a trauma that resulted in injury, and 17.3% experienced psychological trauma. For a thorough review of the impact of trauma on quality of life and health among individuals with mental and substance use disorders, we can have another presentation later on. So with organizations and for staff, trauma-informed services bring to the forefront the belief that trauma can pervasively affect an individual's well-being, including physical and mental health. For behavioral health services, provides trauma-informed practice offers many opportunities. It reinforces the importance of acquiring trauma-specific knowledge and skills to meet the specific needs of clients, of recognizing that individuals may be affected by trauma regardless of its acknowledgement, of the understanding that trauma likely affects many clients who are seeking behavioral health services, and of acknowledging that organizations and providers can re-traumatize clients through standard or unexamined policies and practices. So with the stresses of the importance of addressing clients individually rather than applying general treatment approaches. So this presentation provides clients more opportunities to engage in services that reflect a compassionate perspective of their presenting problems. We can potentially provide a greater sense of safety for clients who have histories of trauma and a platform for preventing more serious consequences of traumatic stress. Although many individuals may not identify the need to connect with their histories, trauma-informed services offer clients a chance to explore the impact of trauma, their strengths, and creative adoptions in managing traumatic histories, their resilience, and relationships among trauma, substance use, and psychological symptoms. Implementing trauma-informed services can improve screening and assessment processes, treatment planning, and placement, while also decreasing the risk of re-traumatizing. The implementation may enhance communication between client and treatment provider, thus decreasing risks associated with misunderstanding the client's reactions and presenting problems, or understanding the need for the appropriate referrals for evaluation and traumatic specific treatment. Organizational investment in developing or improving trauma-informed services may also translate the cost effectiveness in the services are more appropriately matched to clients from onset. So we, as an essential ingredient to organizational risk management, it ensures the implementation of decisions that will optimize therapeutic outcomes and minimize adverse effects on the client and ultimately the organization. The key principle is the engagement of the community, clients, and staff. Clients and staff are more apt to empowered, invest, and satisfied if they are involved on the ongoing development and delivery of trauma-informed services. An organization also benefits from work development practices through planning for, attracting, and retaining a diverse workforce of individuals who are knowledgeable about trauma and its impact. Developing a trauma-informed organization involves hiring and promotional practices that attract and retain individuals who are educated and trained in trauma-informed practices on all levels of the organization, including board as well as peer support appointments. Trauma-informed organizations are invested in their staff and adopt similar trauma-informed principles, including establishing and providing ongoing support to promote. With this practice in addressing secondary trauma and implementing processes that reinforce safety and of the staff, even though investing in a trauma-informed workforce does not necessarily guarantee trauma-informed practices, it is more likely that services will evolve more proficiently to meet clients, staff, and community needs. Advice to counselors. The importance of this presentation. The history of trauma raises various clinical issues. Many counselors do not have extensive training in treating trauma or offering trauma-informed services and may be uncertain of how to respond to clients' trauma-related reactions or symptoms. Some counselors have experienced traumas themselves that may be triggered by clients' reports of trauma. Others are interested in helping clients with trauma but may unwittingly cause harm by moving too deeply or quickly into trauma material or by discounting or disregarding the client's report of trauma. Counselors must be aware of trauma-related symptoms and disorders and how they affect clients in behavioral health treatment. Counselors with primary treatment responsibilities should also have an understanding of how to recognize trauma-related reactions, how to incorporate treatment interventions for trauma-related symptoms into clients' treatment plans, how to help clients build a safety net to prevent further trauma, and how to conduct psychoeducational interventions, and when to make treatment referrals for further evaluations or trauma-specific treatment services. All treatment staff should recognize that traumatic stress symptoms or trauma-related disorders should not preclude an individual's mental health or substance abuse treatment, and that all co-occurring disorders need to be addressed on the same level in the treatment plan and setting. For example, helping a client in substance abuse treatment gain control over trauma-related symptoms can greatly improve the client's chances of substance abuse recovery and lower the possibilities for relapse. In addition, assisting the client in achieving abstinence builds a platform upon which recovery from traumatic stresses can proceed. Many people who have substance use disorders have experienced trauma as childhood or adults. Substance abuse is known to predispose people to higher rates of trauma, such as dangerous situations and accidents while under the influence. And as a result of the lifestyle associated with the substance abuse. In addition, people who abuse substances and have experienced trauma have worse treatment outcomes than those without histories of trauma. Thus, the process of recovery is more difficult and the counselor's role is more challenging when clients have histories of trauma. A person presenting with both trauma and substance abuse issues can have a variety of other difficult life problems that commonly accompany these disorders, such as other psychological symptoms or mental disorders, poverty, homelessness, increased risk of HIV and other infections, and lack of social support. Individuals who seek treatment for substance use disorders have histories of one or more traumas. More than half of women seeking substance abuse treatment report one or more lifetime traumas. And a significant number of clients in inpatient treatment also have subclinical trauma stresses, symptoms, or post-traumatic stress disorder. People who are receiving treatment for severe mental disorders are more likely to have histories of trauma, including childhood physical and sexual abuse, serious accidents, homelessness, involuntary psychiatric hospitalizations, drug overdoses, interpersonal violence, and other forms of violence. Many clients with severe mental disorders meet criteria for PTSD. Others with serious mental illnesses who have histories of trauma present with psychological symptoms or mental disorders that are commonly associated with a history of trauma, including anxiety symptoms and disorders, mood disorders such as major depression, dysthymia, bipolar disorder, impulse control disorders, and substance use disorders. Traumatic stress increases the risk for mental illness, and findings suggest that traumatic stress increases the symptom severity of mental illness. These findings propose that traumatic stress plays a significant role in perpetrating and exacerbating mental illness and suggests that trauma often precedes the development of mental disorders. As with trauma and substance use disorders, there is a biradical relationship. Mental illness increases the risk of experiencing trauma, and trauma increases the risk of developing psychological symptoms and mental disorders. For more comprehensive review of the interactions among traumatic stress, mental illness, and substance use disorders, refer to the next presentation. An organizational approach that focuses on how trauma may affect an individual's life and his or her response to behavioral health services from prevention through treatment. There are many definitions of this presentation and various models incorporating it across organizations, but a trauma-informed approach incorporates three key elements. Number one, realize the prevalence of trauma. 2, recognize how trauma affects all individuals involved with the program, organization, or system, including its own workforce. And 3, responding by putting this knowledge into practice. This begins with the first contact a person has with an agency. It requires all staff members, such as the receptionist, intake personnel, direct care staff, supervisors, administrators, peer supports, board members, to recognize that the individual's experience of trauma can greatly influence his or her receptivity to and engagement with services, interactions with staff and clients, and responsiveness to program guidelines, practices, and interventions. This includes program policies, procedures, and practices to protect the vulnerabilities of those who have experienced trauma and those who provide trauma-related services. This is created through a supportive environment and by redesigning organizational practices with consumer participation to prevent practices that could be re-traumatizing. The ethical principle, first, do no harm, resonates strongly in the application of this. This involves a commitment to building competence among staff and establishing problematic standards and clinical guidelines that support the delivery of trauma-sensitive services. It encompasses recruiting, hiring, and retaining competent staff involving consumers, trauma survivors, and peer support specialists in the planning, implementation, and evaluation of trauma-informed services, developing collaborations across service systems to streamline referral processes, thereby securing trauma-specific services when appropriate and building a continuity of this. As consumers move from one system of service to the next, this involves re-evaluating each service delivery competent through a trauma-aware lens. The principles described in the following the services of conceptual framework. These principles comprise a compliance of resources including research, theoretical papers, commentaries, lessons learned from treatment facilities. Key elements are outlined for each principal providing services to clients affected by trauma and to populations most likely to incur trauma. Although these principles are useful across all prevention and intervention services, settings, and populations, they are of the utmost importance in working with the people who have had traumatic experiences. Advice to the counselors: implementing trauma-informed services, recognizing that trauma affects a majority of clients served within public health systems. The National Center for Trauma-Informed Care has sought to establish a comprehensive framework to guide systems of care in the development of trauma-informed services. If a system or program is to support the needs of trauma survivors, it must take a systemic approach that offers trauma-specific diagnostic and treatment services, as well as a trauma-informed environment that is able to sustain such services while fostering positive outcomes for the clients it serves. It also offers technical assistance in the implementation of trauma-informed services.